Tubercular otitis media, or TOM, is a rare but serious form of chronic otitis media caused by Mycobacterium tuberculosis. It accounts for less than 1% of chronic suppurative otitis media cases and is often underdiagnosed due to its atypical presentation. TOM can develop through multiple routes: hematogenous spread from pulmonary TB, direct inoculation, Eustachian tube spread, or contiguous infection from nearby structures. The primary causative agent is Mycobacterium tuberculosis. Unlike pyogenic chronic otitis media, TOM typically presents with painless otorrhea, multiple tympanic membrane perforations, and severe hearing loss that is disproportionate to clinical findings. Other signs include granulation tissue in the middle ear, facial nerve palsy, and progressive mixed or sensory neural hearing loss. Microbiological and histopathological tests are crucial. AFP staining has low sensitivity, but gene-expert PCR is highly effective in detecting TB DNA and rifampicin resistance. A biopsy may reveal cascading granulomas with Langerhans giant cells. Imaging with HRCT temporal bone or MRI can help assess bony destruction and intracranial spread. TOM can cause facial nerve paralysis, labyrinthitis, mastoiditis, and intracranial complications like meningitis or brain abscesses. Persistent otorrhea and hearing loss can become permanent if untreated. The cornerstone of treatment is anti-tubercular therapy, ATT, following WHO guidelines. This includes an intensive phase of HRZ therapy for 2 months, followed by a 4-month continuation phase with isoniazid and rifampicin. Drug-resistant TB requires second-line medications. Surgical intervention may be necessary in cases of mastoid involvement, facial nerve compression, or severe hearing loss, with options like mastoidectomy, tympanoplasty, or cochlear implantation. Early detection and ATT provide a good prognosis, though hearing loss may be irreversible in delayed cases. Surgical rehabilitation may be required for patients with extensive disease. TOM is a chronic, painless, and destructive middle ear infection that should be suspected in cases of non-resolving otorrhea with multiple tympanic membrane perforations. Diagnosis relies on microbiological, histological, and imaging studies, while treatment involves anti-tubercular drugs and surgical management for complications. Awareness and early intervention are key to preventing long-term hearing impairment.